Imagine handing Medicare back $30,000, all because you thought your team was providing quality care until the numbers said otherwise. Now here you are getting penalized and having to hand back money that's almost a year's salary. And by the time you receive that data, it was too late to fix it. If it's too late to fix it, it's too late to win. You've already been judged, penalized, and compared to benchmarks that don't even reflect your current reality, nor does it take into account the specific limitations of your practice specifically. That's a vicious cycle a lot of medical practices are currently stuck in. They're reacting to lagging data after the fact, chasing 1,000 different metrics from different entities, and wondering why their quality scores never seem to match the quality they know that they're delivering. One, the data is inaccurate, nor has it been proven to be effective. Two, under fee for service, you got paid for what you did. You saw a diabetic patient 7 times, you got paid 7 times. Straightforward. The patient ended up in the ER or was getting admitted, that was a hospital's problem, not yours, right? You'll see them afterwards when they get out. Not anymore. Under value-based care, that same diabetic patient with uncontrolled A1C, high ER visits, readmissions, the PCP is getting burned too. So now think about your quality improvement interventions. If your team is focusing on prevention screenings like mammogram or BMI while your largest population is uncontrolled diabetics, you're setting yourself up for a cost penalty you never see coming. And not just with traditional Medicare, but Medicaid and Medicare Advantage too. You're getting penalized from both ends of the sword if you see them all. MIPS and HEDIS both look at chronic condition management, readmissions, and ER utilizations from Part B claims. And that's the problem. You have to realize where your biggest risk factor is before you get penalized when you can actually do something about it. And I guarantee you, the entity who took 52 years to realize that putting the entire Social Security number on the vulnerable elderly was not a good idea is not, I repeat, is not going to be the one to save you. They're trying to get their money back. They're not giving you a heads up on what to fix, and you can't fix what you don't see. At least HEDIS tells you majority of what you're doing wrong in the current year. MIPS only gives you data on what you submit, unless you join their program. The rest, if you don't have the technology or the manpower, you have no idea what's going on. And if you have no idea what's going on in other measures, that also means you can't possibly see the collateral damage that happens when one intervention breaks another. So what does that look like? So let's take that same diabetic patient, because I don't want you to think that this is only tied to readmissions and ER visits and it's tied to every single facet of your practice, because they're probably not compliant with medication. That's why the A1C is uncontrolled. That is medication adherence. That's transition of care. That's probably your SDOH. Your intervention choice must be connected to where you are hurting the most in your patient population, because it will affect every single thing in your clinic, whether you realize it or not. You must also understand what things will be affected, how they will be affected, and who they will affect. And if you don't know where that is, what impact changes are you really making to the practice, and how is that helping or harming not only the patient, but the quality provided overall? Because at the end of the day, the survivability of the organization depends on your quality improvement initiatives under value-based care. What do the numbers show so that you can keep majority, if not all, of your money? And so with MIPS, that means you need to be 2 years ahead of that data currently monitoring. And in my opinion, that's where connected data changes everything. It gives you visibility and the opportunity to do something about it before the penalties hit, when you actually can, but also make it a patient-centered approach relying on specific practice data from the very beginning. Because honestly, most clinics think that they have a data problem. It's really not the data, it's the connection between the data. When I work with clinics, I tell them you don't need more reports. You need relationships between the reports that you have that help you see what's helping and what's hurting you the most. Your MIPS, HEDIS, payer scorecards, satisfaction surveys, they are not separate stories. They are chapters within the same book. You just haven't connected the pages yet. So the focus is on connecting all of the patient data points across HEDIS, across MIPS, UDS if you're federal, with MIPS and HEDIS, internal KPIs, everything, all the data that you can possibly collect about how your clinic is actually performing, because you want to create a clear, unified picture identifying patterns, overlaps, gaps, collateral damage, and you want to identify this before you start making any changes whatsoever. We want to simplify the process. We want to check the same quality standards for every patient that meets the criteria. Because one patient can be on Medicare Advantage this year and they fall under HEDIS, and then the next year they could be on traditional Medicare again because they want to get home health, and so now they fall under MIPS. And so then we're going to hop back and forth, no. We're going to create one standard set, because that also simplifies it for the office so that there's less confusion, there's less back and forth. If we know that you are 65 and you have 3+ chronic conditions, or you have more than 5 medications, or you didn't go get your screening last year, we want to get to a standard process of what can actually create an alert. Because once you do something over and over and over and over and over, it's easy then to see the patterns, the abnormalities, the outliers that stick out. You want to get to that type of point with your staff. So in the last video, we discussed which report to go through to get the most data, all the way from CAHPS to HEDIS, including MIPS. So now you should have questions like, how many patients are 65 plus with an advanced care plan? How many patients have 3 or more chronic conditions? How many have 5 or more? How many of those chronic conditions are uncontrolled? How many are dual eligible? How many patients have 5+ medications? How many patients have part of the chronic condition, CHF, chronic kidney disease, or uncontrolled diabetes? Now we want to shift from data discovery, what's happening in the clinic, into decision-making support. This is where we actually connect those dots, because we've already gathered the data. Now we want to see what the numbers actually say. And then we need to make sense on how those moving parts interact, what the actual gaps are, what should you measure to report to win in MIPS, because that is coming up at the end of the year. Where should you focus your limited resources first? You need the ability to translate scattered reports into focused action plans with clear next steps for measurable improvements, and the ability to monitor that proactively throughout the year, especially if you don't have the resources to overhaul your technology to meet these administrative burdens. Because the best way to decrease administrative burden and spend resources wisely is knowing what you should fix first, what is actually affecting revenue or patient outcomes, and to what capacity, and which metrics really matter right now. The next question is, which of these gaps matter the most? And that's where the connection phase comes in. It's the missing middle piece, that critical pause between where do we start, what do we need to fix first, and let's fix it. This is where we pause to prevent unnecessary damage and start building systems that allow you to see impact before it happens, not after, even if you are limited in technology. We do that by quantifying impact. This is basically a systemic approach to scoring each metric we're being measured for outcome risk. That's how you start to see the relationships between your operational gaps, patient outcomes, your workflow risk in your specific practice. Because not everything that looks urgent is actually critical, and not everything that seems small is harmless. So, what exactly do I mean by that? Let's say that your data shows 42% of diabetic patients have A1C greater than 9. 30% of COPD patients miss their annual wellness visits. 15% of hypertensive patients are uncontrolled. Which one matters most? What is, I don't have a clue, Alex, for 200. So looking at these, how would you decide which way to pivot first? Which intervention should be implemented first? Which area do we want to focus on? Which one of these are the most critical? Which one's costing us the most money? They're all connected to chronic conditions. They all have high ER visits. Of course, readmissions, they're in the chronic condition category. And they're all monitored by both MIPS and HEDIS. And all have the potential for high penalties. So how do you choose? You need to quantify the outcome risk. So we calculate something I call the final prioritization score. Your final prioritization score equals your severity times your frequency times your visibility times your volume score, cost score, and systemic reach bonus. Let's dive a little bit into what each means, and then I will do a walkthrough example showing you exactly what this would look like so you can see exactly how to do this in your practice. So the first three, severity, frequency, and visibility, is part of an RPN, which is already used by other industries. It's known as your risk priority number. And they pretty much look at severity, occurrence, and detection. But as we are medical, I also wanted to know how big is the patient population this is affecting. And I wanted to remove cost from severity because clinical impact and cost impact are two separate entities in my book when it comes to medical practices. And then finally, I needed a way to also quantify the interdependent relationships between the metrics and entities themselves, which is why I added systemic reach. We are trying to see what metric is hurting us the most. So when you look at severity, you want to think, what are the practical consequences for the patient and the practice if this continues? So an example of no clinical impact for severity, like a 1, would be like an issue that does not affect patient health, safety, or outcomes. So let's say it's something that we are actively and currently doing and measuring. However, we're just not charting it in the right structured field. It's not being captured properly, but we are doing it. And so when we are looking at the frequency, we're not looking to see how many times a patient with uncontrolled diabetes comes in or how many times they went to the ER. We're quantifying the practice's reliability and scoring the workflow, not the condition of the patient or the disease burden. We're assessing the system's behavior to see how often does the workflow fail when it should happen every time like clockwork. And then for visibility, how likely is it that the team would catch this issue before it causes harm or loss? Because the lower the visibility, the higher the risk. Comment proactive down below if you want the guide that walks you through this exact method, and I'll send it over to you. So then we look at volume score, and we're going to score accordingly. Does this affect 75% of patients, 50, or less than 10% of patients? Because a small issue that touches 70% of your patient isn't a small issue anymore. It definitely needs your attention, but you have to be aware of it first. So building on from your volume score, you want to look at your costs. And yes, you want to include your denials in there, but you want to look beyond just your denials. And this is where you can include things like documentation. So one of the most important things I like to look at in cost is your RAF classification. So say two issues, both have an RPN score of 240. Both had high ER utilization. They both have pretty significant high costs, but one has a low RAF. Which one do you tackle first? Of course, the one with the low RAF score. High cost, low RAF means that care is expensive. but patient appears healthy on paper. This would clearly show that we have a documentation issue, because if we are saying that this patient is chronic, there's a coding issue, maybe something isn't showing up in the structured cells or whatever. This is an expensive mistake and should definitely be weighed in when looking at outcome risk. How expensive is this problem in time, money, or wasted effort? Then we give it a score of 1 to 5. So when we're looking at our cost drain, is it a significant cost, multiple staff, lost revenue? Does it create overtime or burden and overwhelm? Is it visible cost per case? Does it add friction, but it's manageable? We want to score the cost and the resource drain. And so beyond volume and cost, now you want to layer in the systemic weight. What, where, and who else could it impact? How many different areas or domains does this specific measure stretch across? You add 1 additional point for each additional bucket the metric meaningfully touches. So we looked at these 10 categories in the data collection section. So now let's say that, again, we're back to the same diabetic patient. Let's say that A1C greater than 9%, we know that its primary data bucket is chronic conditions. But in the example we gave, the cross-touch is also poor medication adherence, health equity, coordination of care if there is high ER or readmissions. So the systemic reach would be +1 for each additional bucket that it takes. That way, when you are scoring where you should actually focus, you can see where the impact would be the biggest, where the impact would be the most costly. So then by the end, you have your final prioritization score. So your final score, again, equals severity times frequency times visibility times volume times cost times systemic reach. Okay, let's go back to the previous examples we were using with chronic conditions. We're going to go back to the original ask of the 42% of diabetic patients have an A1C greater than 9, 30% of COPD patients miss their annual wellness visit, 15% of hypertensive patients are uncontrolled. Right now, before I walk you through this, comment below and let me know which one you think would be the winner, where you would focus on, that would be the most critical. And then after I reveal the answer, let me know if you were right. So when we look at 42% of diabetic patients have an A1C greater than 9, we're going to score this one severity 4, major clinical impact. This issue directly contributes to worsening conditions, complications, or avoidable escalations of care. Uncontrolled diabetes drives kidney failures, blindness, neuropathy, vascular disease. We have to have it under control. If the A1C stays above 9, damage accumulates. So then when it comes to visibility, we're going to give this a 2. It is common knowledge, and it is sometimes discussed. It also affects almost 50% of the patients, but most of the prevention happens after the appointment. So this is going to be a 2 for visibility. Then for frequency, we're going to give it a 3. This is inconsistent hit or miss reliability. System reliability varies depending on the day or staff. Tracking, documentation, or follow-up is not dependable. What is missed here is making sure the patients come in to get their annual A1C, but there is a standard process for greater than 9. But the follow-up after to make sure that there is a decrease in result is what is missing. So for frequency, we're going to give it a 3 because it's inconsistent, it's hit or miss. There isn't a fail-safe system set up in place. Then for volume, of course, we're going to score this accordingly at a 3 because we're at 42%. Then in cost, we're going to give this a 5, very high cost impact. There's clear financial loss or heavy recurring operational burden. There's high ER and readmissions. There are also multiple diabetic measures we're not compliant with, increasing administrative burden and utilization costs. Then for the systemic reach, we're going to give this one a 5. This is located in the chronic conditions. This is medication safety and adherence. This is ER utilization, hospitalization. This is care coordination. This is health equity, SDOH. We're going to give it a 5. So then we go to 30% of COPD patients miss their annual wellness visit. So for the severity for this one, we're going to give it a 2. It's low clinical impact. Care is delivered correctly, but the issue makes it harder to see, verify, or monitor without affecting health outcomes. This one is tricky because care was delivered correctly, but this is a workflow issue. Do we call patients to get the wellness visits, or do we wait for them to remember? We need to treat this like a well baby visit. It is mandatory. They're never going to call to set it up. So we need to be more proactive in this. And then it's visibility. This is going to get a 5. It is hidden. It happens silently. Few realize it's even an issue, and it only happens behind the scene. Many do not know we are currently getting penalized for the patient not getting their wellness visit. The burden is on the patient to schedule the appointment, which is not reliable. And then when we look at frequency, we're going to give this a 5. It is consistently missed system failure. There is no reliable process in place. Catching, tracking, and documentation rarely occurs unless by accident. There is no system in place to make sure patients attend their wellness visit, nor does staff check when the patient comes for a sick visit to see if they have even scheduled their annual wellness visit, or to make sure that it's scheduled before they leave. Then cost is going to be a 4. High cost impact, visible revenue reduction, or significant staff time. Although this measure is about wellness visit, the cost for COPD patient is significant. Therefore, increase in wellness visit may help to decrease readmission and ER visits. It's high because this is a breathing issue. These patients feel like they can't breathe. They're going to go to the ER if it's after hours and there's no other support and they have no home health set up. They're going to go to the emergency room. So this is going to drive cost, but the goal is to get them in for their wellness visits, assess their functional status, so that then you can put resources in place that hopefully will help to decrease admissions as well as ER visits. So the systemic reach for the COPD patients is going to be a 7. So it's the standard chronic condition, the medication, the ER utilization. This is also preventive care and wellness, care coordination, the health equity. And for this one, we are going to also add patient experience, engagement, and safety. This is where we're going to think to trigger research. Are the COPD patients who miss their annual wellness visits the same ones who end up back in the ER, don't get their inhaler teaching, don't get their immunizations, their medication reconciled, their anxiety screening? We need to see where the gap opportunity is in this systemic care management failure area. That's basically all this score is helping us to do. So then we go to 15% of hypertensive patients are uncontrolled. So right off the bat for severity, this is going to be a 3. Moderate clinical impact. The issue can lead to delayed adjustments, loss of control, or avoidable disease progression over time. This got a 3 because it only affects less than a quarter of the patients, but can definitely lead to disease progression. And so the visibility for this one is going to be a 1. It's fully visible. Everybody knows it's a problem, and it's on several touch points of the patient pathway. There is a standard process for hypertension when it's 140/90. There's a standard process already in place. But the frequency for this is going to be a 2 because it's sometimes missed, occasional gaps in tracking, documentation, or workflow. But the system generally works. So even though there is a standard process for anyone with a BP greater than 140/90, what's missing is a process for catching it every time and making sure the final documented BP at the end of the year is within normal limits, or making sure they adhere to medications or ER follow-up after discharge. But as you can see, we're not really doing too bad on this measure because it affects less than a quarter of the population. But we're still going to give it a 2. And so then for volume, this was going to get a 2 because it's 10 to 24%. And then cost is going to get a 3. Moderate cost implant, measurable overhead, but not destabilizing. These patients do end up in the ER and readmitted, but there is heavy penalty because they are only admitted for observation, mostly not inpatient, and follow-up is poor again, driving up utilization costs. And a lot of the patients are at RAF scores, show that there's a documentation issue. So they're going to get a 3 for cost. So then for systemic reach, this was going to get 6. And the 6th one that's going to be added on to this one is the data and documentation quality, which probably the other ones would as well, but specifically the RAF score, we're going to document this bucket. By the end, you've got a final prioritization score. Final score equals severity times frequency times visibility times number of patient population times cost times systemic reach. So when you look at the final scores, you see that the winner is the COPD in the annual wellness visit with 4,200. Comment below if you guessed correctly or if you were off, because you have to remember these patients have trouble breathing. Most of them are on oxygen. And a lot of them find it cumbersome and burdensome and tiring to even get out of the house, to be honest. So there are a lot of things you have to think about when it comes to trying to make sure that your patient-centered approach is actually centering the patient and their needs, and not like you're just sitting around trying to decrease wait times. Now that you've scored your outcome risk, now we need to visualize them. It does nothing for us to have a list of measures with percentages beside them. We plot them on what I call your hotspots heat map. This is a visual representation that gives you clear insight of what deserves your attention now versus what can wait. It basically maps the ripple effect from the collateral damage so that you can easily see it. And that's how you shift from reaction to strategic focus. This is where traditional PDSA models fall short and why it's no longer adequate as a quality improvement in healthcare any longer under value-based care. It tells you to test change, but it skips the connection between the data and the patient, as well as the analysis of what that change will touch. Because those hidden gaps is where you discover the truth about your system's behavior. Not only what's documented, but your true core operational gaps. By finding those, you can clearly define where true improvement is needed and mitigate damages and penalties if at all possible. Because the truth isn't in your scattered reports. It's in your patient's experience when no one's watching. And whether the quality of care your office provides is actually helping them get better. Because at the end of the day, this really isn't about metrics or benchmarks. It's about the care of the patient. So now you have all your different measures, and then you're going to put them into each category. We color code the risk. It's simple. Plot your scores, color code red, orange, yellow, and green. Where are the hot spots on the heat map? Where are we healthy? What metrics are an emerging concern? Which ones are at risk? Where are the real critical threats? This completely eliminates the need to wonder what should you improve first. You can immediately see who or what needs support immediately because the data are already telling you the whole story. This is the step where your efforts stop being about compliance and becomes part of a patient-centered approach that has real impact. You stop chasing the measures from MIPS and HEDIS and all these different entities and fearing reimbursement penalties and start forecasting on outcome growth and true patient health. Because you have to remember, at the end of the day, behind every number is a patient, a staff member, and a provider doing their best in a broken system. So it's not about pointing fingers. It's not about blaming the patient. It's about seeing what our practice story is. And then what can we do about it if it's not the way that we want it to look? Is this making sense? Comment down below if you think this is something useful to your practice or not. Because it is my belief that once you can see your risk clearly as the one in charge of quality improvement, you can manage your practice future more confidently. And you definitely don't want to be making a mistake by focusing on the wrong area or not doing anything because you're rural and right now you think you're exempt. There are about 77,000 small, rural, and solo practices who thought the same thing until they got hit with penalties this past summer. Again, the most vulnerable population with the most administrative burdens, lack of resources, and potential for financial penalties are the most impacted by MIPS. Based on 2023 data, 2 years behind today, of the 14% of MIPS eligible clinicians will receive a penalty up to 9% penalized, 49% of them were solo physicians, 2% small practices, 18% were rural practices. And when it came to the maximum penalties, 13% were small practices, 29% were solo providers, and 2.5% were rural. When you look at that, you think that's not so bad. Well, that out of 77,910, when you translate those pretty percentages MIPS put out, that's 22,290 small practices, 37,801 solo practices, and 13,852 rural practices that probably were unaware that they were going to be penalized this year and have their funds taken from them to be dispersed to larger facilities. So 2% may not sound like a much, but 13,000 rural practices sound like a lot to me. But wait, I thought rural clinics were exempt. Yeah, a lot thought that. Rural health clinics themselves are exempt from MIPS adjustment, but clinicians within rural health clinics are subject to MIPS adjustment because MIPS is tied to the physician fee schedule, the physician's fee schedule. And even though a 2019 study found physicians caring for more medically complex and socially vulnerable patients were more likely to receive a low MIPS score even when they delivered relatively high quality care. Now think about the thousands of updates they've had since this report came out in 2019. And tell me if you think it has been for better or worse for your practice specifically. Now think about how you have or have not been performing since 2023 until now, because that's the next penalty. And it's too late to do anything. Submission deadline is roughly 1 month away, give or take a few days. Now tell me, is this a path you deem sustainable or not? Because I think not. So to recap, you learned why it was important to gather and connect your data. You learned how to quantify and rank outcome risk. And now you have a roadmap for where to focus your energy next. In the next video, we'll take one of those top priorities and I will show you how I dissect it before I come up with my first goal statement. I want to know the who, what, when, where, why of why this is happening, including how much and how many. Then from the root cause answers, we turn that into a measurable goal. In my opinion, by using this method, we replace trial and error with precision and foresight, because after all, these are patient lives at stake, and there's only so much stretching of the staff we can do. So if you feel like that type of knowledge is beneficial to you and your primary care clinic, make sure you subscribe, hit the notification bell so you don't miss any upcoming videos. And if you are looking to take action immediately, don't forget there's either a link below or you can DM me proactive, where you can get a free worksheet that teaches you exactly how to calculate your own final prioritization score for your medical practice. Because clarity does not come from more data. It comes from connecting the data that you have. So again, if you found this video helpful, make sure you like and subscribe. In the meantime, DM me if you need help, and I'll see you in the next video.